Hi, I'm Dr. Vonda Wright, and this is Hot for Your Health. Join us for conversations on the bleeding edge of science, health, and culture as we bring you tech innovators, thought leaders, and the movers and shakers who are transforming science fiction into your new health reality. Hi, everybody. I'm Dr. Vonda Wright, and thank you so much for coming back to another episode of Hot for Your Health. And I'm really excited today to bring you a fascinating guest who is triple boarded, meaning Dr. Rocio Salas-Whalen is going to talk to us from her hats of medical doctor, from her hat of being an endocrinologist, and from her hat of being an obesity medicine board certified doctor. So we get all three amazing knowledge bases in one person today. Dr. Salas-Whalen has a private practice in New York, and we're going to put all her practice information in the show notes, and really serving a population, at least what I see you doing on social media and in talking to you, who is hungry and soaking up information like a sponge. So we need to just make sure we're giving them the right information. So I'm so happy to have you today.
Thank you so much for having me. I've been looking forward for this podcast for a while.
Absolutely. So let's start with the question on everybody's mind. It's a question I had, and then I got control of it in the ways that I talk about. But why is managing our body composition and our weight in midlife, and I define that as about 35 to 65, so hard? What are the factors? Because it's not like we just stopped trying.
Definitely. I think in that period of time and that age range that you just mentioned, it's like we're almost set to failure, right?
Really?
It's like all the environmental factors are preconditioning us to either gain weight or make it very difficult for us to lose weight. And it can go from hormonal changes, physiological changes, to environmental changes, right? When we're talking about environmental factors, it could be higher stress in your job is when you're at peak professionally, and that's going to take a toll on stress and sleep, or start having children later in midlife too, right? Or in later life than before. Then we go into our hormonal changes, where the estrogen starts to fluctuate in perimenopause, and we know that perimenopause can happen even in the mid-30s to late 30s. So those changes in estrogen is going to affect our body composition. It's going to affect our metabolic rate. So it's not just one thing that it's being an obstacle for us to lose weight. It's from different directions, right? And then you enter in your mid-40s, and then you have aging parents, teen children, more stress, more changes. So that's why what I mean when I said we're set to failure is like we have to overcome many things. And I see this every day in my office, patients following their exercise routine, eating the same way, or even decreasing their caloric intake, right? There's no changes in their weight.
So I think an interesting thing that there's so much to unpack in what you just said, but I think an interesting position women are in now, and I certainly was that way, is that millennial women, the oldest millennial women are about 43 right now. I think of millennials as the 20-year-olds. Well, not really. Millennial women have aged enough over the last few years that you're entering perimenopause. But at least in my crowds, and I see this in my millennial children, they're waiting much longer to have children. And certainly I did. I had my last child, my biologic child, at 40. So we're going from building our careers. Maybe we're only starting to think about having families in our early 30s. And then we do that, and bam, we're either raising young children at the beginning of perimenopause, or in my case, my daughter was going through puberty and I'm going through perimenopause, and the house is filled with all the roller coaster. And so I hear you, there's a lot, but this is a unique situation in this generation, right? That we have women bearing children later, we have women rising in their careers. and hitting on the stumbling block of perimenopause. Talk about stress.
Exactly. And added to that, aging parents, right? Raising small children. I also had my first child at 38 and my second one at 39. So in your 40s, you're in a very special situation that our prior generations weren't in. It was raising still relatively young kids, but then dealing with sickness in our parents. That, and I see that a lot in women, and it adds a lot of stress. We have a lot on our shoulders.
Well, it's funny you mentioned that. Today is my father's 84th birthday. And culturally in our family, my parents live with us. And so in my household, we had preteen, we had perimenopause, we had people in their 80s. My husband's running around taking care of everybody. But, certainly in my sandwich generation, it is stressful when they're in the ICU and my daughter is navigating middle school. Your daughters are about to enter middle school. Holy cow. But so there's a lot of stress going on. But can you just clarify why estrogen fluctuation changes our body composition? And if we're thinking about, why would our bodies be designed that way? What's the advantage of shifting our adipose tissue from periphery to visceral? Why would that be our body's design, do you think?
Well, I think it's just our own body. I don't want to say shutting down, but shifting gears, right? I think it's just shifting gears, taking us from our fertile years to our non-fertile years. But as many things in the human body, doesn't mean that they're beneficial. It doesn't mean that we cannot do something about it, right? Or also, we are living so much longer now, right? I mean, before our expected life was
40, 50, yeah.
Now 80s, 90, and it's being prolonged every decade because of the advances and the knowledge that we have, right? So really, those changes in our body composition can be modified. And I think going back a little bit on women entering midlife, the advantage that younger women have now in their 20s or early 30s is the knowledge that we are passing along, right? That's the time to build in your bank of health, of muscle mass, of discipline and lifestyle. So when you enter this age gap that we're talking about that is stressful, you are armed, right? You have 50% already under your belt, and then easier to deal with the other 50% of the factors that we mentioned.
I love that approach that you just said. Number one, I when I speak, I always say, my parents said I could be anything I want to be, and my goal is never to lie to my daughters that they can be anything they want to be. I want them to be everything they can be, equally. That's a political conversation. Equally, but also from a health perspective, coming in armed with the knowledge that they're not going to hit a giant roadblock and be set up for failure, as you've said, that they're going to know how to jump over the barrier. And so, people are used to listening to me talk about lifting heavy weights. And I know you would agree with building muscle mass, about how we do cardio, about eating great nutrition, including paying attention to protein. But a conversation that has to happen in midlife and that you are amazingly qualified to talk about is now the use of what seems to be an unprecedented miracle intervention of the GLP-1 inhibitors, right? So I would just love, because I've never talked to my audience about this before, give us a GLP-1 101 session. What is it? How does it work? Why is it effective? Because then I want to talk about how to pair lifestyle with it so you get optimum health benefits.
Definitely. And I think GLP-1s are going to be, in our lifetime, the biggest event in medicine that we will see.
Like the polio vaccine.
Unless
the
cure of cancer comes up in the next few decades, I think the GLP-1s are what's going to revolutionize medicine and change the way that we practice medicine. And really add years to our lifetime.
Okay.
Right?
So what are they?
GLP-1s are synthetic hormones. We make this, it's a hormone that we make it in our small gut, in our small intestine. And what they do, they play with your metabolism. So these hormones help regulate hunger hormones, satiety hormones. So at the gut level, when you are on taking, so what we hear commercially, semaglutide, tirzepatide, Ozempic, Mounjaro, all of them, they're analogs, they're synthetic versions of the hormones that we make. So these hormones can increase your satiety hormones when you start eating. So you get fuller with half of what you normally would need to get full. And then in between meals, it suppresses your hunger hormones, right? So the majority of patients, they have 2 or 3 small meals a day, feeling physically content and satisfied. But we have receptors to these hormones, many places in our body that we're discovering more and more. And one of those places is in the hedonistic eating center in our brain, right? Where we anticipate a reward either from food or beverage. With these hormones, the GLP-1s, they block that. They remove the anticipation of our reward from food. So if there's emotional eating, anxiety eating, boredom eating, even binge eating, it takes it away. So when the patient starts on it, at the beginning, they reach for this food or beverage because it's their behavior. They have no feedback. They don't get any.
No pleasure. There's no pleasure zone activation, right?
And the behavior changes. Now, patients do enjoy their food when they're hungry and they eat, but then they get satisfied. But you eat for energy and you enjoy while you're eating, but there's no emotional reward.
Oh, well, you know what I typically say to my people, I just said it yesterday to a group of them. They were complaining about they're so tired of eating chicken as protein because, and I'm like, well, listen, people, remember what I say? We are eating for fuel, not festivity, right? So exactly what you're saying is that we get what we need for fuel, but there's no party associated with it anymore. Like there's no balloons and confetti when we eat anymore. It's just to fuel our bodies. Well, that's interesting what you've said, because what I hear you say is that there's a metabolic function with hunger. Well,
yeah,
there's a metabolic function, but there's also an emotional function that this drug covers both bases, interestingly. What happens when, I'm thinking to myself, when you provide more of a hormone, the receptors to that hormone actually downregulate because our body loves homeostasis. So do you see, as we add more hormones, do you see downregulation of the receptors so that, I don't know where I'm going with this. I'm just thinking physiologically, what happens over time?
You mean if the patient gets used to the medication and stuff?
Yeah, do they get used to it, or does it take more because there's fewer receptors in the future because of downregulation?
Really interesting the way that you're thinking, and this goes to show, and I think this is a big misconception that it happens in doctors, it happens in people. Weight loss is extremely complex. Weight loss is not a simple going down the numbers on the scale, and I feel like that's something that is shifting very slowly and gradually. But you have to understand that weight loss, fat loss, it's complex and it involves many other things, right? And if we just concentrated or thinking of weight loss as dropping the pounds and using the medication, then yes, nothing changes and it becomes harder and harder, and patients require higher doses every time to get the same effect. The key to prevent that from happening, because there's a threshold that we reach, right? There's a certain number of dose that we don't go above it, right? So to prevent that from happening is we have to guide the patient through the weight loss journey to build muscle, to get into the discipline of building muscle, strength training, protein, to give the best chance on the medications to do their job,
right?
And not downregulate or let the patient get used to the medication and require higher doses. I do body compositions on every single patient that I start on a GLP-1. And it's really And again, we are learning as we're going.
Mm-hmm.
One of the things that I saw in patients is the patients that lost muscle didn't gain muscle. I couldn't go down the dose when we were in a maintenance weight, right? They require higher and higher doses. The patients that were able to maintain muscle, gain muscle, increase the protein intake, I was able to bring to the minimal dose possible. So it's, I always tell my patients, 50% of the journey is going to be the medication. The other 50% is going to be what you do outside the medication.
How do you determine or screen for your patients their readiness to change? Because you've got a group of people maybe that they just want a quick fix. We'll take the injection, or whatever form you tend to prescribe, and they're hoping that the miracle will happen. And then you've got what I see in my longevity programs is I've started to assess people for their willingness to change, because I can tell them all the things, but until someone is willing to implement the behaviors, because it's never a quick fix. See, not even with GLP-1s. How do you assess someone's readiness to change? How can a person say to themselves, okay, I'm ready for the hard work. Doing hard things is going to be in my vocabulary. How do we do that?
So for me, being an endocrinologist and an obesity specialist, I like to say that I'm the last stop in their journey. By the time they come to me, they're ready. They're expecting that. They're there. They're ready to make the change. But I feel like it's primary care or those first filters where the conversation needs to happen and assess where the patient is ready. I would say the majority of patients that with obesity through most of their life, they're ready, right?
They're just tired of this yo-yo. Yeah.
They're tired of being let down by the healthcare system, by society, right? Some of them have lost the hope to reach out for help. And it is really sad because we're missing a huge part of people that can benefit from this medication, right?
Interesting. How do you fit it into, before these became available, really for people who were morbidly obese and their health was just spiraling, or even people who were, and I say this, were only 100 pounds overweight, because we know a lot of people like that, highly functional people, but still 100 pounds as a whole person. And I operate on Wednesdays, and in the very next room is a bariatric surgeon. So how does layer out for me? When do we try simple lifestyle? When do we layer in GLP-1s? At what point do we say, okay, we've got 300 pounds to go. Maybe we bariatric and I don't know this algorithm. Can you help me sort it out?
So there's guidelines in regards to...
Oh, there are. Okay.
So, well, for patients that, and this is talking about the BMI, and we'll talk about the BMI.
Yeah, BMI.
The current, that will change. The current guidelines is a BMI of 27 plus one comorbidity. It could be high blood pressure, osteoarthritis, depression, anxiety, sleep apnea. They qualify for weight loss medications. BMI of equal or greater than 30 without any comorbidities, they qualify for GLP-1s or weight loss medications, right? I like to go further than that because we should and we can. So I do body compositions on my patients, and I use percentage body fat, visceral fat, and muscle mass. Those are my three key components to determine when a patient will benefit from the medication. Now, I see very often a normal BMI of 23, of 24, with high percentage body fat, high visceral fat, and very low muscle mass.
Skinny fat.
Those patients, if we go by the guidelines, we will miss to offer help with the medications, right? But if we go by further, more information as percentage body fat, then there's more people that we can help and prevent disease, right, from happening.
So what is the ideal range? What is healthy range? Not trying to be, not cosmetic range. What is healthy range for those three values for a midlife woman?
So muscle mass is going to vary a lot from their height, but ideally more muscle mass than body fat in regards to muscle mass. percentage body fat in women, we like it to be between 19 to 28%.
Right.
And in men, between 10 and 20%. And in visceral fat, depending on what you're using, either an MRI, which is the gold standard, but we don't do MRI on every single patient. The next one is the DEXA, which also it's some radiation. We don't do that every single visit. And then the third one is an impedance machine, which is a very commercial that we have. And that gives us a scale in the visceral fat, and then we just go by that scale in the visceral fat.
Okay. All right. So the more muscle, the better. The less visceral fat, the better.
Sure.
You know, so even within the normal range, if we say percent body fat for women is 19 to 28, 27 plus one comorbidity, like they've already got arthritis, they've already have insulin insensitivity, GLP-1s could be an option for them.
Definitely.
But here's the thing, right? And I'm sure you do this in your practice. I have a friend, I practiced in Pittsburgh for a long time, who wanted to add this GLP-1 administration to their practice, but they didn't just hang a shingle and say, okay, come get your prescription. They did it as a part of a program. They have a nurse that monitors you. They partnered with a gym. They have a nutritionist. Is that the holistic type of way you think people should be seeking out this kind of weight management?
Exactly. And I think I like to say this, and I say it very often, the efficacy and the safety of these drugs will depend who is giving them to you and their expertise and their experience, right? If you're going to somewhere and they're just quantifying in the scale every visit, if it's working or not working, that's not the right way.
Not enough.
You need a multi-discipline interaction with these medications to have the best outcome. Definitely exercise, weight training, personal trainers for patients that never exercise, nutrition to help them with protein intake, right? And we could talk about muscle loss in this medication. And then you talk about the medical part of how to handle this medication, their doses, handle other medications that patients can be on them, and then essentially need to be titrated, decrease, stop as they're losing weight, right? So it's a multidisciplinary that requires a lot of safety steps for the patient to have the best outcome, and not all those side effects that we're hearing so much on the media, right?
Well, and so what you've just framed is that this is a serious, multidisciplinary medical intervention that can have profound changes in people's current life and trajectory of health. It is not something that you just order off the internet or it's not a supplement. It is a serious medical intervention for the best benefits. So we've been talking mainly about weight loss and percent body fat and lean muscle mass, but as I'm reading and learning about this, there are other profound health effects that can happen by using this. Let's summarize a few of those. It's not just weight loss, apparently.
Weight loss. So it improves. One of the first parameters that I see improvement, even before the weight loss starts, is improvement in blood pressure. So your blood pressure, your glucose control. I mean, there were designs for type 2 diabetes. They improve kidney function. They prevent cardiovascular disease. And the big one that is coming, I mean, as an obesity doctor, I've seen these effects, right? But as a medical society, we always want to see the evidence, right? That the studies, the papers, so they're being conducted. But the one that I'm waiting here, filing my nails, prevention of cancer.
What?
Of the incident. Yes.
Because of sugar feeding cancer?
Yes, obesity. Obesity puts the patient in an pro-inflammatory state. And we saw that with COVID. Prior to COVID, I think that the big reason we're hearing so much about these medications and obesity is because it was the perfect storm. COVID, and the availability of these drugs. Prior to COVID, when we talk about a patient about obesity and possible complications, we were talking 10, 20, 30 years later, right? You may develop type 2 diabetes in 10, 20 years.
Right.
So patients with obesity, they thought they had enough time.
Mm-hmm.
And with COVID came
Yeah.
nowhere. And the patients that had obesity or were overweight
So sick.
were more sick, more ICU visits, and higher mortality. Why? And we found out why, because obesity, the fat tissue, visceral fat, it's a chronic inflammatory state.
Yeah.
Right? So we know that obesity causes more than 13 cancers, including colon, breast, postmenopausal breast cancer,
Yeah.
stomach, esophageal cancer. So
Wow.
by decreasing obesity, by preventing obesity, we are actually going to prevent many of those cancers. And I can see the incidence decreasing because of this.
That is profound. I was first a cancer nurse and have been so I started my career taking care of young women in the hospital, the fight of their life, lots of them breast cancer. But what's alarming now is the trend towards younger and younger people having cancer. And we always thought of that as a midlife and beyond disease. But I wonder, and you're probably going to shake your head, yeah, Vonda, good for getting the point. But 70% of our population now is has a high fat or frankly obese. So as our population obesity increases, if young people, and you see this all the time in children, living in a chronic inflammatory state, it's a perfect setup.
It's a perfect setup. And talking about childhood obesity, it's the incidence is on the rise.
Unbelievable.
We have studies now showing that preconception weight in the parents, in the mom and the father, can predispose the offspring or the child's weight in the future, right?
Really?
So let's say you have a woman or a man thinking of fertility and they have obesity and they're overweight. We aid them with medication. We help them achieve, and this is what I do for my patients, achieve a healthy weight prior to conception. Then you are not just changing our generation weight, but our future generation weight and health.
So, that's so funny. It's profound. There are many things that I've learned since I had my daughter that I thought, oh my God, I should have done this. I should have done this. But you know what? She's great. They're all great. But all of our children are great. But the fact that the 9 months before you get pregnant, then the 9 months you are pregnant, then the 10 months postpartum, all that is critically affecting your child's health because of your health. And is this why I keep reading about, oh my God, the fertility rate's going up because of GLP-1s? And it's because we're decreasing body fat content. People are becoming less inflamed, more healthy, the reproductive organs work better. Holy cow, it's all related.
It is. It's all related. And as an example, PCOS, right? Polycystic ovarian syndrome.
Right.
Polycystic ovarian syndrome goes hand in hand with weight gain, right? I mean, there are some patients that have a normal weight.
Oh, yeah, not usually.
That's not usual. And I would challenge that with a body composition to see that BMI is normal, right? But once weight loss improves and patients with PCOS, we know that fertility increases, right? So it's expected that this is going to happen. And it's not just a physiological change, it's a psychological change also in the patients, right? It's an environmental change in the patient. So it's positive. It's all positive outcomes when done correctly.
So do people have to stay on this forever?
It's not a straightforward yes or no.
Oh, okay.
But it varies on the patient. Varies. Where were they health-wise, metabolically-wise prior to gaining weight, having obesity, overweight, right? I would say for patients that have struggled with obesity since childhood, they're less likely that they'll be able to maintain the weight with that medication. For somebody who had a healthy weight through their young adulthood, puberty, young adulthood, there's more likelihood that they can possibly be on medication. I always tell my patients, the higher muscle mass that you have, and you increasing your chances of maybe maintaining your weight either without the medication or with a low dose long term for maintenance.
So, because we've talked about the fact that these work on the hedonistic, addictive centers in our brain, is there any role for cognitive behavioral therapy as an augment to the building muscle so that those triggers that may have stimulated eating behaviors could also be worked on? Or is it so chemical that also is not, that's not necessary on GLP-1s?
I always want to let my patients know that they still have control, right? I don't want them to feel that the control was taken out of them with these medications, because then they become dependent on the medication, right? So through their journey, you always have to let the patient have some sort of control in their choices, right? And I think resistance training, protein in their diet, that's more in their control. And if they can do that along with the medication, then that puts them in the best case scenario, right? And you and I know, because we lift weights and we like this lifestyle, that once you are in that lifestyle of lifting weights, of the discipline, it becomes part of your life, and you like it, and we like feeling
Extra,
right? So it's harder to get out of that place once you're there.
yeah. So in a really tight summary, what I hear you saying is that for overall health, adiposity leaves you in a chronic state of inflammation, which is a precursor of all diseases, including cancer, and that by working on a part of your brain, as well as the hormone secretion from your gut, the way GLPs help is actually bidirectional, but alone, it can only go so far. You need to add the lifestyle in, the weightlifting, because there's better effect. You just said when you build muscles, then just lose the fat mass. And so what an astounding augment to the overall health, because for a long time before these started being widely used, they've been around a long time apparently, but before they started being widely used, I felt like we were kind of just in a spinning wheel of you try, then you get your bariatric surgery, and then lots of those people regain all the weight because we haven't gotten to the root cause. We've just plugged up the dam. So it provides a new level of hope for people, but it is complicated and a medical intervention, not just a supplement you buy off the internet. Is that a summary that is true?
Yeah, it is. And I think one thing that we didn't talk about, it you just mentioned about patients being in that hamster wheel, that I through interviewing thousands of patients with obesity, is that the patients were listening to us. The patients were doing what we were recommending. They were exercising, they were eating healthy, and it was just not happening. And why? Because obesity is multifactorial, right? We can talk about the cause of obesity. It's multifactorial. It's not a lifestyle problem. There's genetics, talking about conception, family history, hormonal changes, PCOS, perimenopause, menopause, aging, metabolism decreases, environmental factors, stress, sleep, work, where we live, where we're exposed, BPA, plastics, endocrine disruptors, and then lifestyle, right? So really, it's a medical treatment. Obesity is a disease. And by treating it, by eating less and exercising more, we weren't treating it as a disease, and we were not getting the results that we were hoping for.
At what age should we intervene like this? Because I know lots of obese 7-year-olds and 12-year-olds. And here's the deal. This generational information you've given us, that preconception weight of the parents affects lifetime weight of the child. I mean, I would observe, because I'm a sports doctor, right? I would observe the changes in body composition across the 30 years I've been in medicine, that athletes used to be always fit, but now athletes generationally at lower levels, we've just accepted that some of them are dealing with obesity and yet doing sports. So this generational approach, now you're telling me that young people starting to replicate are predisposing. So it truly is generational. It's not just because your grandma likes to fry food. It is generational biology.
Now, if we go by guidelines, they're approved for 12 years and above.
12.
12 years and above.
Oh, okay. I thought you were going to say 18.
12 about obesity, and 10 years and above for type 2 diabetes.
Oh.
So potentially off label for weight loss at 10 years and above, right? Now, talking about childhood obesity, it touches a lot of sensitive chords in people, right? How are we giving this to children? Why? I can tell you that I see patients in their late 50s, 60s, 70s, 80s that they've struggled with their weight since childhood.
Yes.
It takes a physical toll, a mental toll, and they're in their 70s, 80s, still trying to lose weight, still on a diet of the diet of the day.
And you're exhausted from it.
I had grown men cry in my office. If you can relieve those decades of suffering, stress, physiological and psychological, why not if they're safe? Why not offer a child with obesity the best case scenario?
Yeah.
Now,
because then you're setting them up for a lifetime of health versus a lifetime of disease. And listen, we know when I measure lactate threshold in, this place that my office is, the Lake Nona Performance Club, we have a metabolic lab. And so I measure people's lactate threshold and predict even before frank diabetes, the onset of diabetes. And we know that then predicts Alzheimer's. So it's not just our physical body, it's our brain body, right?
it's our mental health. Mental health. Now, treating a 12-year-old, a 10-year-old with these medications, it requires a lot of expertise, right? Because you have to approach it in a very not medical way, but to not also develop some eating disorder or body dysmorphia, right? You require someone with expertise, and they're pediatricians that are obesity board certified. That should be the right person, right?
Well, and certainly your approach is this. I mean, and my approach is this. I never talk about the cosmetics reasons to get in shape. I actually don't care what people weigh. I care how much muscle they have. I weigh a lot more than you would think a little 5'4" person should weigh because I am muscly, right? I don't actually care what people weigh. I care about their body composition. And I say pretty frequently, I don't care if you fit into the little black dress for your high school reunion. That is not why we're here. And so when you say it has to be done carefully so that you don't develop brain thinking patterns that send you down a road to eating disorders or body dysmorphia, I hear you, because that's not what we're here about, right?
And at that age, it's more easier for a child to think about the external effects of the weight loss, right? And that may be the reason that a parent is bringing them to them or not accepting them. But it's harder to explain to a child the internal benefit health than to an adult, right? So you have to be very careful to not make it a cosmetic improvement for a child.
Right. And I think it's also then important and I'm looking to you for language, to approach accepting all body types, because there is a whole conversation about that. Why are we fat shaming? Accept all body part types, blah blah blah, which is fine. I mean, I'm certainly not trying that approach at all, but I think the conversation is really medical. If you are carrying 200 pounds of adipose tissue, this is not about how you look in a bathing suit or whether you can qualify as some kind of beauty queen or whatever. This is about saving your life and saving you from cancer. And who doesn't want that, right? That is the conversation, right?
That's a conversation. Preventing disease and longevity, and adding quality years to your life.
Right. Well, and I just want, as people, I just needed to say that because I'm not telling people to go to the gym so that they can run around in their little brief tops. I'm telling you, you can go sweat and lift some weights. That is the mindset shift. Oh, and by the way, muscles are the Spanx of your body, and you will change it. But that's the bonus. That's the
Cherry on top. I always tell my patients, whatever happens here is the cherry on top.
That's right. That's right.
But if you exercise for weight loss, then it becomes a hassle. But if you exercise for your health, it changes your mindset. It does.
Yeah. Amazing. Amazing. Well, what have I forgotten to ask you? I think we've covered a lot, and I've certainly learned a lot. GLP-1s are not in my wheelhouse. I refer people out, but I have to tell you, endocrinologists are hard to find. Doctors certified on obesity medicine, hard to find. Just like people have taken the time to become experts at menopause, hard to find. Certainly hard to find an orthopod willing to talk about it. But
and I think that's where we do what we do, because we cannot see every single person as a patient, right? There's just one of us. But through social media and through these platforms, we're able to provide that knowledge and education to patients and even to some physicians, right?
That's right. So is there anything in closing you'd like to make sure that people know that we haven't talked about, or to reemphasize something that's important to you?
I think it's really important to understand that people with obesity struggle internally and externally, and we cannot judge people from being on these medications or make them feel bad, right? I think we have to, at the moment that we accept obesity as a disease, then we can accept these medications as a safe treatment to it.
Got it. Got it. Well, thank you so much for being with me today. And I'm so excited to have you in August at the Midlife Mastery Retreat we're having. The women are going to love these conversations. So thank you so much. And I'll talk to you soon. I'm Dr. Vonda Wright. See you next week.